Thank you, Mr. Chairman. And I appreciate the witnesses coming today. You know, the monumental challenge that our country is facing has come in large part due to the failure to develop and deploy sufficient diagnostic testing in time to monitor and control the spread of the virus. In February, on the 29th, after it became clear that CDC's tests would not be able to perform, FDA began authorizing the emergency use of molecular diagnostic tests. And since then, FDA's authorized more than 110 emergency use authorizations, has issued more than 110 authorizations for diagnostic tests. And that's done a lot to increase our overall testing capacity. Unfortunately, we still don't know much about the accuracy of these tests. And while we might typically expect the test to undergo large patient studies to determine the level of accuracy, the emergency use authorizations require a much lower standard, so only a small number of validation steps. While most screening tests will never be 100% accurate, false negatives can lead to devastating consequences. For example, there have been reports that the White House test that they use to screen individuals before they visit the Oval Office may produce false negatives 20% of the time. So Dr. Hahn, FDA has said that it has asked test manufacturers to conduct follow-up accuracy studies on tests that have received emergency use authorization. Can you tell us how many of these tests have you requested follow-up accuracy testing on? And of that number, how many have been shown to be accurate?
Thank you, Congressman, for that question. And just want to emphasize the point that you made, which is that in an emergency situation, our EUA authorities allow us to look at the risk-benefit. And early on in a pandemic with limited numbers of supplies, but reagents to test the actual diagnostic accuracy, we rely upon a certain set of data to make that decision initially. We have actually required in the post-marketing setting the collection of data for a number of companies, and they have come back to us with those data, and we have made adjustments to the EUAs for those tests. But even in those situations where we haven't required formal post-marketing assessment of the tests, we have collected on our own and with the companies and with academics real-world data. We incorporate all those data into our assessment of the tests. And I'll just take, sir, for a moment, serology tests, where we've taken over 20 off the market based upon our own independent evaluation in U.S. government. We will continue to make those efforts, and we will continue to look at those data and adjust our recommendations and tell end users, be very transparent about the operating characteristics of the tests so that they can use them in the best way possible.
About how many adverse events reports have you received on diagnostic tests so far?
Sir, I'll have to get back to you with the exact number. We've received a number, and I mean double-digit numbers of reports about all of these tests, but I'd be glad to get those data for you, sir.
Okay, and just to confirm, if a follow-up accuracy study comes back and a test shown to be inaccurate, you've moved and you'll continue to move to take those tests off the market?
Absolutely, sir, and we promise to be transparent and post that on our website.
Thank you very much. I want to ask Dr. Redfield a question about digital contact tracing. Do you agree that digital contact tracing tools can enhance our traditional contact tracing efforts, particularly proximity tracking tools that use Bluetooth technology to identify people at risk of COVID-19 infection?
Thank you very much for the question. Clearly, these new digital technologies that have been developed for contact tracing are important to be evaluated and to see how they will contribute. I want to emphasize, though, that first and foremost, the most important component, we believe, of contact tracing is the human capacity to do that, and this is why we're working to aggressively increase the number of contact tracers. But we currly are in the process of evaluating it to see if it's value added.
I only have 45 seconds. Dr. Redfield, let me just point out, I would really think there would be a shame if we took the technology from the 1980s and didn't employ the technology that we have today. Bluetooth technology can tell you who you've been around within a certain proximity with great accuracy, with great speed. It can be anonymized so that no one knows who the particular person is. But if you have your Bluetooth on, you don't have to know who you were standing next to at the protest or in the restaurant or in the bar. If a person test is positive, It can go into a system, and Google and Apple, MIT, UCSD are working on these things so that you could be automatically, almost in real time, warned that you've been in proximity to someone who's tested positive and can behave accordingly. For speed and for your accuracy, I hope you'll give a good look to Bluetooth technology, because it can be private and it's certainly more accurate and certainly faster than the technologies we used back in the 1980s. We can do better, and I yield back.
Yeah, I just want to emphasize, Congressman, that we are aggressively evaluating that technology with Google, Facebook, to actually see how it impacts it. So I agree with you; it's really important. We have programs evaluating each of it in partnership with Google and Facebook right now, and we will continue. The question is just to see exactly the best way for this technology to be used. It's not a question of not seeing it as something that potentially could be very important.